The next person, Fabien Schneider. He's a program unit manager in MSF Toronto, and he has been on many MSF field missions. He also develops and manages innovative projects supporting MSF operations. And it's focused on digital learning and telemedicine. And please, Fabien, come up. Welcome.
Thank you.
I realized I didn't really know what telemedicine was, so I had found that the American Telemedicine Association defines it as telemedicine is the use of medical information exchanged from one side to another via electronic communications to improve a patient's clinical health status. Telemedicine includes a growing variety of applications and services using two-way video, email, smartphones, wireless tools, and other forms of telecommunicating technology. Is that right?
It's totally right. Thank you. Well, thank you for having me. I'm the lucky one, so I'm finishing with a short talk on telemedicine. I probably just need the remote to change my slides, or yeah. Hello. Sorry. Voilà. So you have the definition, and you have the good one. So I think we are in agreement. We can add that telemedicine is educational and clinical. I will have a few slides just behind me, but it's not a presentation, so it's more of a talk. I think today is for me a great demonstration that it can be challenging to guide and support our team on the field toward delivering a certain level of care and when complexity has to be handled. But it's not, when we look at telemedicine, it's not only the clinical challenge, it's also the fact that we are facing major difficulties in deploying ourselves in challenging contexts. And I will mention, for example, the attack on medical care that we are seeing happening in Afghanistan, South Sudan, Yemen, and many other countries that limit, in fact, the capacity we have to deploy our best clinical expertise on the ground. Our operation as an organization are becoming more and more decentralized de facto. We have to use more remote management strategies and approach of all kinds, including dealing with clinical cases management by the distance. We are obviously working in very, very sensitive context. The Middle East is a great example today, but not only. South Sudan, I think, like we all know, the missions in the middle of the 90s to be very similar to what they are today. So we are working in very sensitive, challenging context. And I will mention here, I will understand later why, that we are sharing loads of information that are medical information, like in big number that we need to take care of as we do in developed countries. The volume of our medical activities is very high. We all know that, but not only. It's very complex to deal with. We are managing severity and complex cases daily. Many of those cases require often additional expertise or additional support, whether it's clinical or educational. Unfortunately, we don't necessarily have, even if we are a very large organization today, the full capacity in place to support our team with specific expertise on the field. Studies have demonstrated that telemedicine is used in developing countries as it is used in developed countries, and it's mainly for educational and clinical purpose. And this is very important. In MSF, present and past usage of telemedicine has been for real-time telemedicine. I will come back a little bit on this later, and also for non-real-time solution. So real-time, it's really at the same time, two people connecting through the phone, through video conferencing, and non-real-time is more the concept of the store and forward. So you're posting a case on the platform and obtaining clinical expertise within a matter of hours or a few days. MSF Canada is involved with MSF Spain in piloting a project using hybrid model of telemedicine, which is a combined real-time and non-real-time systems. And this model has demonstrated that a hybrid model of telemedicine has the potential to be a powerful tool to providing pediatric distant clinical support for complicated cases in resource-limited setting. In the case of Niger, it's resource-limited context, but also a context which is challenged by more complexities. In Somalia, earlier, OCB has also demonstrated that the introduction of real-time telemedicine significantly improve quality of pediatric care in remote conflict settings. So really Somalia was time of the conflict. MSF was not able to be present physically with expatriate, with foreign resources. And it was found to be clinically supporting the team, but it was also found to be of a great added value for the knowledge of our colleagues on the fields. When we look at synchronous telemedicine, synchronous systems like real-time, we come across the fact that it presents substantial technological challenges to deal with, and it requires significant HR commitment in order to be sustainable and to function. But leverages out the benefits across all patient outcome, as well as to users for professional development. In 2009, MSF France, that time was Dr. Jean Rigal, who was the director of the medical department, with Laurent Bernardo, have introduced into MSF operation, and that was the first time, the concept of telemedicine services, the medicine by the distance, through using a non-real-time solution, which is a store and forward, a platform that was and still is developed by Professor Richard Wotton. Today, such services is widely used for taking care of pediatric patients. We're going to have a quick look on some of the data here. So we have here accumulation of all the cases, pediatric cases between 2010 and today. And here what we can see that pediatric represents 54% of all telemedicine referral cases, and has had cases from 44 countries. This number since 2009-2010 continuously be on the increase. The majority of the cases are general pediatric queries, followed by radiology, and then internal medicine. And the larger number of referrals of all the projects in MSF are coming from the DRC. The so-on-forward system is a very reactive one, and the median time to specialist first response in hours is 3.5 hours, which is very successful. So we can see a breakdown here of the pediatric telemedicine queries since 2010. So this reflects what I just said. And we can see, I don't know if I have something here, maybe not, that we did a breakdown to understand better the point. And what I'm going to talk about here briefly is a breakdown of internal medicine queries. And this somehow shows that what the telemedicine is handling, aside of a volume, is also handling a complexity. So telemedicine handle and give face to rare medical case that, unless documented through accumulating data, which in the case of the telemedicine platform, remain visible within the volume of MSF data in a whole. Specific gaps on specific diseases have been identified with using telemedicine services, and an expertise is being developed de facto through managing them and through expanding networks of specialists that are not, who are not available within the current MSF setup. Telemedicine is also engaging and educational. So we have documented in different projects great interaction among MSF advisors with the medical team at project level during clinical discussions or when receiving an expert opinion. We also have been able to document that the use of telemedicine has made possible in a very short period of time an active use of telemedicine. Has made possible the effective application of protocols and better use of, by the doctors of diagnostic tools. There is for sure a lot of a lot, maybe not, I don't want to be too negative, but there are limitations for telemedicine for sure. Among them, we can identify, and this is documented, we have the lack of infrastructure globally, and it's totally valid for MSF too. There's also the fact that services may be costly when using certain type of satellite connection, and maybe mainly the lack of human capital. MSF today seems to engage toward using more telemedicine services, so is progressively dedicating human resources to telemedicine. There is no telemedicine with the contribution of you and medical professional of different kind. It's not the technologies that are going to solve the problem, we all know that. Investing in human resources with a low scaling up usage of telemedicine together with the technology and will allow developing the networks of medical people that is required to support any form of telemedicine systems. There are challenges technically. Well, there can be many, but I'm going to name a few. One is the bandwidth and the hectic availability of bandwidth in our field. For example, satellite communication. Once again, there are international initiatives that are made to solving the problem of hectic availability of bandwidth. So we can expect that in 3 to 4 years that we have a better context. But this is a problem because when we do real-time telemedicine, especially if we are expecting dealing with complexity, then the quality of the session can be poor. Another issue is that telemedicine systems need to be flexible and interoperable. This is a standard of the industry, but when we look at how MSF is able to adapt its operation, when we use telemedicine, we certainly want those systems to be adapted to our needs. So we need a lot of flexibility. I pointed before the fact that telemedicine is handling complexity, and the Store and Forward platform has helped to identify the severity. And our system, or the system we're going to acquire, need to be integrated and need to be able to communicate with MSF health information systems and technologies. There is a major point of concern when we look at telemedicine, and we need to improve as an organization. It's all about security and privacy of the data. I believe, like where you live, maybe for most of you, your medical data, they were very well protected as well as your privacy. We should take care of that because it may not be the case depending on how we use telemedicine as an organization. So security and privacy. Telemedicine is the use of medical-grade technologies by healthcare provider to transfer, exchange, or discuss patient health information. This is another definition of telemedicine. And the key feature of telemedicine is, in fact, patient privacy and data security. Today, MSF teams are using systems of telemedicine inside or proposed by MSF. And sometimes, because they may not find the expertise that they are looking for, they're going to source this expertise outside. So this is a major challenge. We need to investigate the reliability, the standardization, and the independence of the platform that we're using as an organization. We are living, as per today, privacy and security aspects and other criteria outside of our control. And this is detrimental to, and will be detrimental to continue scaling up telemedicine in the organization. So we've seen that, try to explore the fact that telemedicine demonstrates its potential to improve the quality of care on the field. Voilà. But it is expected that the workload for telemedicine could be substantially higher than it is today. So the idea of the iceberg is an idea given by Daniel here. So what we're seeing now in terms of need is what we have here. It's at the top of the iceberg. There is a lot more that we can do with telemedicine. Various levels of telemedicine capability are requested by all our missions and projects. And the demand is for real-time services. I want to connect directly with a doctor somewhere, with an expert somewhere. Whether it's for highly specialized context or on the day-to-day practice. And there is a demand for telemedicine expertise that is increasing very rapidly. So, as we are integrating telemedicine in our operation and medical methods, we are going to work alongside with moving forward constant evolution, constant technical evolution, constant medical evolution, and with working with emerging and interoperable solutions. So it implies that there is a bit of change management within the organization to keep open to something that we are not very familiar with. Telemedicine for pediatric care, as for telemedicine in general, have to establish a strong physician leadership to advocate and provide appropriate telemedicine services. So in the end, there is no one answer. There is no single answer. There are only a series of best answers at a particular moment. There is no one solution for telemedicine. There is more work to be done toward creating a telemedicine ecosystem that MSF can function with, and within we'll have different kind of solution, and over time we'll constantly adapt to the availability of the bandwidth is growingly available worldwide. So in a matter of 3 to 5 years, we'll have more access. The most important thing is not the technology, but it's the people. So we need you to support and we need you and your commitment and engagement to support using telemedicine. We'd like to finish by rapid acknowledgement. This is the structure of the current telemedicine services. It includes a team based in Canada, MSF Canada, a couple of years had nothing regarding telemedicine, has developed a structure that allows, and we hope, building up an expertise and making that expertise available for the operational center, together with implementing part of the services. We are coordinating and administrating the international platform of telemedicine. And on the left side of the screen, you can see the allocators who are like Daniel, Raghu, Sophie, Jared, who is here, Peter Saranching, locating cases on a 24-hour base, 365 days per year. And this would not function without the contribution of more than 300 specialists who have dedicating their time, volunteering their time to respond to cases submitted to the platform. Voilà. I would like to thank you very much with the quote of Johan, who say in regard to telemedicine, suddenly you are not all by yourself in the middle of the South Sudan, and this is very true and has been said that way. I would also give an acknowledgement to the Collegium Telemedicus, particularly to Professor Richard Wooten and Laurent Buonardo. Thank you.
Thank you very much. That was really interesting. I wish I had it the first time I was out with MSF more. Thank you very much. Any questions? We have two questions. You, and that's it. Oh, we forget this side. So I see you have, so we'll actually start with you because I know you had a question before.
Thank you very much for that presentation. I was wondering which one you're emphasizing. Is it the telemedicine interface between the community or the patients and the health workers, or between the health workers in form of consultations?
Health workers, between medical team, doctors, can be nurses too, and either the expert or the medical advisor at headquarter level, or expert outside of MSF. But that, maybe to add on this, what my presentation is on two aspects of telemedicine. If we look at e-health or telehealth, it's a much wider issue, and we're focusing on for now, real-time and non-real time.
Yeah, hi. My name is Monica. I'm from pediatrician from Norway. My question is, I'm quite sure within MSF there are a lot of potentially specialists that want to join. So what do? We're a lot of people not being in the field. We would like to dedicate our time. Is it? Do we contact you guys? Or?
Yeah, you can contact us. The address, the email address here, and you can contact me in the next coming days, and I'll be happy to link you with our coordination. And so what we do, we are looking for specialists. We're looking for specialists who can support the store and forward platform. We're also looking for specialists who can support and dedicating some of their time for the development of real-time solutions. I mean, that would require also some hours of contribution for a week, for example. But I'm happy to assist you in that way. Yeah.
And I'm just also wondering, do we have any telemedicine projects within Styria today?
No, that's a good question. We have some use of apps outside of not the control of MSF, but we know that because of the availability of bandwidth, people are connecting on systems. The question is that, do they obtain appropriate expert opinion? We're not sure. So the idea is to work in 2017 on solutions for the region. However, this said, telemedicine as a store and forward is used in Syria. So because this service is low in bandwidth consumptions, can be used easily in all MSF projects. The only limit of this is the capacity of MSF to handle with a load of cases that the setup would not allow to manage.
One more. It was you there, and then I think we have to stop. We're running.
Well, thank you so much, Angie from MSF Luxembourg. I've been involved with Roni and colleagues with this with this study from Somalia. Yeah. I think you've finished your presentation with the most important point about telemedicine, that those doctors, they told us, we are not alone. We are not left alone in the field. Now we feel like you're following up the cases, and you're giving us your opinion.
Yeah.
So here, my question is for the future for MSF, because now, thank you, Monica, for bringing this point about the Syrian doctors. The Syrian doctors have been left alone for 5 years now. We receive requests about, not only how to manage war injuries, but also about how to manage infectious disease that they have never seen. So what is the future for MSF? Is there a plan to have a real-time training, a capacity building for doctors that they've just graduated or not even graduated, that they perform surgeries now and treating infectious diseases in Syria and other contexts?
Well, that's a good question. Like if I understand your question well, that your question is about whether we're going to train people through telemedicine. It should be the case. I don't have a plan, and we don't have a plan for deploying learning and training through telemedicine. But I totally agree with you that this has to happen. I should, maybe it's a very interesting issue. In the unit that we have developed in Canada, we have developed 2 pillars. One is digital learning, and today we're doing our best to catch up and become among a referent on telemedicine. So knowledge sharing, knowledge dissemination, learning, and telemedicine intersects. And it's going to be very interesting to see how we can work on this intersection between knowledge sharing, learning, training, and telemedicine. Because with telemedicine comes with investments in more bandwidth, better bandwidth, come with investment in hardware, investments in platforms that allow knowledge sharing and learning training. So we're going to investigate more the requirement of the organization in terms of telemedicine, and as we do, we are going to place also in the middle of that investigation, exploring the needs of the organization, learning and training, so that we have systems that will allow education. But the fact is that the educational component is probably among the most benefit you can have from telemedicine. So I'm not really answering to your question because I don't have a plan, and I'm sorry for that.
I think you were handed the microphone, so very quick question and an even quicker answer, maybe.
I don't know if
yeah. No, my name is Luis Encinas. I'm not a pediatrician, but I'm a pediatric nurse, and I would like to insist on this point. Thanks, Fabien, for your presentation. And I think even if it's the last intervention, it's an honor to raise a point that I would like, from the very beginning of this morning, pointing out. You mentioned that there is a possibility for nurses or for people from the field to have as well using this telemedicine. My question is basically, as it's very important to have nursing and medical approach, if there is in this team pediatric nurse or nurse experience that can facilitate. Basically, to be honest with you, if a person in the field has a limitation or a need to talk to somebody and to be supported with the telemedicine or the nursing care, is it feasible? Is it possible? And yeah, that's my question.
Well, thank you very much for this question, because this is a very important one. How I'm going to answer the
Quick one, yes, no, maybe.
Well, the answer is yes. If you look at the model from public and private sectors for telemedicine, those models involve nurses and doctors for different purpose. So it's a combination of So we will. Yeah.
Sure of that. And
which is a very important point. We are not yet at this stage because the structure is not yet fully in place. It's going to take a little while to have the structure in place.
No, it is the same that in the pediatric working group as well, there is no nursing representative. And just using this discussion in the first pediatric days to raise this point and to really highlight the importance of be together and focus on the patient.
Yeah.
That's it.
I'm a nurse too, so I
Yeah,
know
I know,
what it
and
means.
that's for the reason I say.
And my first mission, I had to face a case which I was with another Kenyan nurse. There was no doctor. Everybody was evacuated from South Sudan. I was in Akwem. We had an emergency that came in. It was a breach. We couldn't manage it. We went through the library. We went through satellite phone. It was like 16 or 17 years ago. And today, with the technology, we will probably be able, and not a big investment compared to how much worth a life, would have figured it out.
Okay, I think we have to stop there. Thank you very much.